Good afternoon. I am honored to be here as part of this 3-month progress report. My name is Dániel Szmola, and my research focuses on novel approaches in optimizing bone health. Me and my team are working on developing strategies to improve post-fracture patient care. I'm a first-year PhD student and a fourth-year ortho-trauma resident currently working at traumatology clinic at Semmelweis University. My supervisors are Peter and Zoltan, who guide me in my research, and my SME and SMS are Amir and Marie, who help greatly with their expertise in our projects. My vision is to achieve effective healthcare practices for maintaining optimal bone health, and my mission is to identify these effective protocols for bone health. We are currently undergoing 3 major projects that are interconnected. The first one is investigating the safety and efficacy of post-fracture patients and their physical training. The second examines the impact of nutritional supplementation in the same patient group. And the third is a clinical trial protocol building on the first 2. So our first project title is investigating the safety and efficacy of physical training in post-fracture patients. And this topic might seem trivial, but is critical and relevant, not only because it affects a huge population, but also it still to this day often leads to severe consequences. Only a few number of patients achieve pre-fracture function, and many of them have suffer grave consequences, even death, even despite our best efforts. So I think this is unacceptable and calls for an urgent need for revising the current protocols and having novel ideas to improve these facts. Physical training is crucially viable in addressing these challenges, and it has the potential to mitigate both bone mass loss and muscle strength loss in immobilized patients, which is essential for improving recovery. Our clinical question is, does physical training cause change in clinical outcome markers in this group? And our hypothesis is that optimal training protocols positively affect this patient group. Our search key that we developed is finalized and has 3 domains. We have a pool of around 3,000 articles, and in this pool we have many good key articles, and all consisting of randomized controlled trials, keeping in mind to have matching main characteristics as seen here. This part of the literature has a wide variety of outcomes seen here, and but mainly looking at physical performance measures and standardized questionnaires. After removing the duplicates and finishing the title abstract selection, arrived at, with Luke, at 200 articles feasible for full text selection. And we're currently undergoing this phase. We plan to finish at the 20th of December, which is in 8 days. I hope it's possible. And following this systematic approach, we make sure that we adhere to the highest scientific standards. Our second project looks at nutritional supplementation in the same patient group, and we currently see a nutritional deficiency pandemic worldwide, especially in fracture patients. So with vitamin and protein and micronutrient deficits being common. So addressing this nutrition deficiency, these deficiencies, we have a potential to improve the care of these patients. Our clinical question basically mirrors the first projects. Does nutritional supplementation cause changes in bone-related markers in clinical outcomes in post-fracture patients? We hypothesize that optimized, targeted nutritional supplementation positively affects this patient group with the ultimate implication of reducing mortality. We already have a preliminary search key, which might be also the finalized one, with 3 domains, borrowing 2 from the first project and adding the nutrition domain. With this search key, we found 4,000 potential articles from these main databases. Sorry. And I'm glad to say that we already found many potential key article candidates. So there is a possibility that we will move to the next phase very soon with this project also. I would also like to mention my third project, a clinical trial protocol that is building on the first two. And this is still very much in the feasibility phase, but we aim to have a two-arm protocol, one with nutrition and the other with training. And this would assess the combined effect and the separate effect in the hip fracture patient as an outcome on mortality as primary outcome. But I would also like to include as many feasible outcomes as possible, seeing the literature that there is a big need for example, bone turnover markers and bone mineral density markers. So to summarize, currently we have 3 ongoing projects that are interrelated. The first 2 looks at training and nutritional supplementation in the same patient group. And the third will be developing a clinical trial protocol building on the outcomes of the first 2 projects. And I would like to finish with this quote from Ludwig Wittgenstein: "The human body is the best picture of the human soul." Thank you for your attention.
Thank you so much. The room for questions. Anybody from the audience? Okay, please.
Okay, thank you for your excellent presentation. And I was wondering that how many patients are you planning to involve in your clinical trial in each arm?
Very good question, thank you. This is a key question because it highly affects the relevance of the research, and I would at least try to include 100 per arm if we do the 2-arm, which I would really like, but it is also a question. So.
Okay, thank you.
Okay, Christina.
Congratulations on your presentation. My question is that, as far as we know, fracture patients, especially hip fracture patients, can have many comorbidities. So my question is if there is any confounding that you're looking for, and if yes, what are those?
Yes, this is a huge problem in this patient group. We will have to address it, and many research articles and many in the literature I see it is addressed. They all have a thorough baseline for all of the patient groups. So this includes age and other physical performance. So with having a strong and thorough baseline, I think we can minimize this confounding, but we really have, this is one of the limitations because it affects a lot of elderly patients who take a lot of medications, have a lot of illnesses. So this is a very good question, and we need to pay attention.
Thank you.
Thank you. Oh, one more.
So regarding your second article, so nutritional deficiency is indeed a problem in post-fracture recovery. Are there any nutritional protocols available in your clinic at least?
This is one of my main motivations for this project, that not to be too harsh, but trauma research and documentation is chaotic, very chaotic, and we have problems with it. We're glad if we operate on the patients, and then if the bone and the metals are looking good, we're happy, but there's a whole patient around them. So we really, we really need to take care of the patient too. And nutrition, I feel, is also a big need to look at nutrition specifically, because to answer it in short, we don't have any. We can see overall protein in lab results, but we look at hemoglobin, inflammation, and 3 or 4 days if the patient is okay, they can go.
This is more of a question regarding a protocol, but not necessarily resources. So you have the resources, but a protocol would be necessary.
Yes, yes. If we would have a protocol, sometimes we can have protein supplementation. We have good products for that, and many long-term or chronic care professionals will obviously know that there are many ways to supplement patients, but it is not required, and it is not part of our daily life. So I think it is really a big need, and it would help the patients a lot.
Thank you. It will be interesting.
Yeah.
Thank you. Bernadette?
I was wondering about subgroup analysis, if you're planning to do regarding your first project, for example.
So
subgroup
yes.
analysis. Yes.
We have a huge potential for subgroups. There's for age groups, for different training types. So this is a very wide scope. This approach has a very wide scope, but it is on purpose. So we can see which areas we need to focus on, because I already had, from the beginning, we had in mind that we will have a clinical trial protocol or aim at achieving real-world consequences with this research. So yes, we will have as many subgroup analysis as possible.
Thank you.
Thank you so much. I have a question. Do you plan the third intervention arm in the last study, nutritional and physical activity?
Yes, this is a yes. This is an obvious question. I would like to. That's why I misspoke that I would like to look at the combined, but yes, also the separate. So yes. But then we need more patients. So this is a key question in the feasibility phase. And with what resources and which centers, and so this will be a hard topic, and this is for another day.
Thank you. And how long do you plan to follow up the patients in this?
At least a year. At least a year. It's as seen in my background slide, there is a huge drop-off in patients in the first year. So if we can achieve a better number in the first year, it's already a huge success in my